Would that work? Okay. All right, go time. Okay. We have people joining us. Excellent. Welcome. Come on in, make yourself at home. Make sure that you're muted, and we'll just give it a minute, and then we will get going here with today's event. Welcome, welcome. Okay, I think I'll just turn off the waiting room here. Just to, pardon me. Okay. Okay. Hello, everybody. Hello and welcome. We are going to get started. And so, hello, welcome to our webinar presentation today, hosted by the Ontario Network of CAPC and CPNP Projects. We're hosting this event with the Mental Health Commission of Canada, and we're really pleased to have you here with us today. Joining us are CAPC and CPNP staff from all across Ontario and many other parts of Canada, which is really exciting. So I'd like to begin today by taking time to acknowledge that we work on the traditional lands of many different nations. And today, a path to truth and reconciliation begins with recognizing both the stewardship and the sacrifices of original peoples. We are committed to recognizing the errors of the past, acknowledging the challenges of the present, and contributing to a new and respectful relationship with First Peoples. So the head office of the Mental Health Commission of Canada is located on the unceded traditional territory of the Algonquin Anishinaabe Nation in what is now called Ottawa, Ontario. The network sponsor agency, Camino Wellbeing and Mental Health, our offices are in Southwest Ontario in Treaty 4 territory, an area known as the Haldimand Tract, the traditional territory of the Haudenosaunee, Anishinaabe, and Channahton people. So we invite all of you here to introduce yourself in the chat if you like. Tell us where you're joining from, and you're also welcome to share an acknowledgement of the territory you are joining from today. Okay, so I'm going to launch my screen share here. I'm navigating a little bit of new technology in this shared event, so you'll have to bear with me a little bit. Okay, so make sure that, okay. I like to talk myself through things when they're new. So hopefully everybody is seeing the slide. Is that working? Thumbs up? Thank you. I appreciate the thumbs up. Okay. So today we are excited to bring this webinar to you, and the webinar is called Reducing Structural Stigma in Healthcare, Making Real Change for Quality Mental Health and Substance Use Care, presented by our friends at the Mental Health Commission of Canada. Before I introduce our speakers, let's just take a moment to go through some housekeeping. We are asking you to keep your mics muted to help us with the quality of our recording. And as I mentioned, some new technology that I'm being supported in navigating, and today's webinar will be presented in English with simultaneous French interpretation, which is really exciting. So to activate the simultaneous interpretation, click on the interpretation button at the bottom right of your screen. Hopefully you can see that, and select your preferred language. And we encourage you to enable this interpretation to ensure you can participate in the webinar in your language of choice. The slides are also available in both languages. If you would like to follow along to the slides in French, please select View Options at the top of your screen and select the French option under the heading Shared Screens. And I think that's a little bit of instruction on the next slide, right? There we go. There's a little bit of a visual aid for you. Okay, the session is being recorded, and by participating in the conversation today, we assume your consent. Also, I want to invite you to please watch for an event survey link in the chat as we go. We'd love to hear your thoughts on what we've offered today. Okay, moving right along. This webinar will begin with a brief presentation, followed by a panel discussion, and finally a Q&A. Questions will be answered only during the Q&A period to help us keep things on time. Please feel free to type your questions for the presenters in the chat box or raise your hand. And so here we go. I'm really delighted to introduce our presenters to you. We have Carolina Chadwick, Program Coordinator with the Prevention and Promotion Initiatives team at the Mental Health Commission of Canada. Carolina is deeply committed to promoting mental wellness, psychological health and safety, improving access to quality mental health services for all, and exploring the intersections of education and immigrant settlement experiences. Since 2023, Carolina has focused on addressing stigma and advancing the quality mental health care framework. Also with us today is Hannah Kohler, a senior program manager with the Mental Health Commission of Canada. For over a decade, she has worked to support better access to quality mental health services for people in Canada, championing meaningful engagement of people with lived and living experience, promoting recovery-oriented practice, and prioritizing psychological health and safety in the workplace remain her key areas of passion. More recently, Hannah has been leading work on structural stigma within the Mental Health Commission of Canada and is excited about the transformative potential this work presents to be able to build more safe and equitable healthcare systems in Canada. So please join me in welcoming Carolina and Hannah. Over to you.
Thank you, Sydney, and hello, everybody. We're very excited to be here, and thank you, Sydney, again for this invitation and for organizing this webinar. We are looking forward to sharing with all of you a little bit our work at the Commission on structural stigma. So as Sydney mentioned, Hannah and I will be doing a quick presentation on structural stigma. We're going to be presenting also a little bit on our implementation guide, dismantling structural stigma in healthcare. But before that, for those of you who are not familiar with our organization, I just want to mention really quickly that the Mental Health Commission of Canada is a national organization. It was created by the Canadian government in 2007. And its mission is to improve mental health outcomes for all Canadians by developing, sharing, and promoting different resources, different programs that support research, policy, and system improvement. We have a wonderful library in our website, including training, toolkits. We have a digital newsletter, a magazine, conversation on mental health, great resources for teachers, for parents, service providers, service users. So I want to invite all of you to visit our website, mentalhealthcommission.ca. Next slide, please.
Apologies, am I on the right slide for you, Carolina?
One second.
The objective slide?
Objectives, yes, please.
Yes, okay.
Okay, perfect. So as you could see in the registration page, we have 3 objectives for this session. Number 1, we're hoping that by the end of this session, you are able to understand what structural stigma is and what are the negative impacts of structural stigma related to mental health and substance use. We're also hoping that you gain some strategies and some resources to address or to reduce mental health substance use related structural stigma, with attention to the key principles outlined in our implementation guide. And last but not least, we are hoping that you are able to recognize the importance of having inclusive policies and programs and understand the importance of including the voices of people with living experience, their families who are or who have a struggle with a mental health problem or substance use disorder. Next slide, please. Sorry, I'm not sure if I'm seeing maybe I'm seeing the French slide, but we should be in the question slide.
Yes, it is there.
Yeah.
What comes to mind when you think of stigma is the one that's
okay. Maybe it's the French slide that I'm seeing. Okay. Yeah, so we're gonna watch a video that is gonna introduce us to the concept of structural stigma. But before that, we're gonna talk about just stigma. So I want to ask this question to everybody, and if you feel comfortable, I want to invite all of you to put your comments in the chat box. If you don't want or you don't feel comfortable, that's okay too. So the question is, what comes to your mind when you think of a stigma related to mental health or a stigma related to substance use? So I'm gonna keep a couple seconds. Let me check there. So a stigma refers to all the negative attitudes, prejudice that cause people with a mental health or a substance use problem to be labeled, to be stereotyped, to be feared or discriminated. Unfortunately, in our society, people with a mental health problem or a substance use problem are highly stigmatized. All these negative assumptions, all these negative beliefs lead to seeing people living with these problems as less deserving of care, less treatable, or difficult to treat. There are 4 types of stigma related to mental health and substance use. So we have individual stigma, we have interpersonal stigma, intersectional stigma, when there are other intersections, and we have a structural stigma, that is the type of stigma we're talking about today. So next slide, and we're gonna watch the video, and because I know we don't have a lot of time, so Cindy, if you can stop the video at 1:21, that would be great.
Stop the video at 1:21.
Correct.
Okay. Somebody made a comment about no sound. Okay. I'm sorry you weren't able to hear, Elizabeth.
Yeah, so that must be because we cannot play both videos at the same time. So I think most of the people just hear where it's shared in the main screen. So hopefully we will share the recording and the video after, so everybody can watch it. So we were introduced to the concept of a structural stigma, and as is seen in the video, in the healthcare system, structural stigma occurs when laws, policy, or practices result in unfair treatment of people living with a living experience. That's why it's so important for everybody in the system, for healthcare leaders, for healthcare providers, decision makers and everybody in the system to learn how to identify structural stigma. And the most important is to learn how to dismantle these barriers of care. It is essential that we build a healthcare system that is inclusive, a health system that is supportive for all people, no matter if the person is suffering or is struggling with a mental health issue, a mental health problem, illness, or a physical health problem. Next slide, please. So in the video, there were a few examples of structural stigma in the healthcare system. So you will see here in the slide as well, we have lack of treatment for individuals with a mental health problem. We have excessive wait times compared to physical health issues. We have, this is very common, diagnostic overshadowing, when a person, when many people with a mental health illness or substance use disorder don't get the treatment they need, not having enough resources, not having enough allocation, when the physical space for mental health patients or substance use patients is lower quality compared to other areas of care in the organizations. So I know that was a quick presentation, but then in the with the panel discussion, you will have a better understanding of all these examples of structural stigma in the healthcare system. So now I'm going to pass it over to Hannah, and she will be sharing a little bit of our implementation guide and some of the resources to reduce or to dismantle structural stigma.
Great. Thank you, Carolina. So yeah, Carolina mentioned, next slide, please, Sydney. So Carolina mentioned the implementation guide. So this is a resource that we released at the end of 2023. So it's been out for almost a year. It's a comprehensive free resource that's available in English and French, and it provides healthcare leaders, providers, and others in the health system with strategies, tools, and guidance to reduce mental health and substance use related structural stigma within their organizations or within their settings and healthcare contexts. I'm going to share a little bit about the key principles here, but we'll do a quick overview to give some more time for the panelists. Next slide, please. So within this great document, we share these key principles for structural change. We understand that addressing stigma is really top of mind often for many organizations, especially in healthcare, but a lot don't know how or where to start. So these principles have been synthesized from lessons, insights, approaches, and strategies used by others across the country who are already doing this work. So whether it's through writing policies, developing or running programs or initiatives, providing care, everybody in healthcare has a role to play, and this guide can support your effort. So I think what's first and foremost for me when thinking about reducing or dismantling structural stigma is centering the voices of people with lived and living experience. Prioritizing the meaningful participation of service users in the design, delivery, and governance of any initiative for change, and formalizing their involvement through established models of co-design and shared leadership is essential. Committing to shared leadership models and meaningful involvement is itself an act that challenges structural stigma because it represents a fundamental shift in how we think about the design and the delivery and management of healthcare for people with mental health or substance use health problems. So it's all about making changes, not for them, but with them. So, that whole co-design aspect. Next up, we have, embedding change for sustainable results. You really need to work to embed the change within the structure of your organization or your setting by coding it into policies, governance mechanisms like we just spoke about. And then quality improvement indicators are also another important aspect. It's also important to model change from within to spread influence. So ongoing engagement and education, as well as role modeling and leading by example, that will help facilitate and support buy-in across your programs and with your partners. It's also incredibly important to get explicit support from senior leadership. It's really about ensuring long-term success and sustainability. You need buy-in from senior leadership and the support of passionate champions. We do hope that you walk away from this presentation looking at structural stigma, knowing that you're, as a frontline worker, which most of you are, that you realize you're also a key player for addressing structural stigma. However, ensuring support from senior leadership is really key for ensuring sustainability. It's also important to think about growing through tension and dissonance. So anyone seeking to address structural stigma must also be willing to embrace disruption and anticipate resistance to change. I think that's really critical takeaway, is remembering that change will be difficult, it will be uncomfortable. And it's not because that it's needed, but the complex ways in which power dynamics and individual, organizational, or societal aspects of discrimination interact with one another. So you'll be questioning things like long-held assumption, challenging norms in our everyday, and things will be uncomfortable before they get better. Something that we often forget about or leave to the end as an afterthought is evaluation. So it's important to evaluate outcomes and monitor and with moderated measures. So knowing the importance of undertaking evaluation and research, setting targets and goals, and monitoring your progress. Evaluation and research design should always involve input and direction from people with lived and living experience as well. And finally, acknowledging the intersectional nature of structural stigma and other inequities. I'm sure many of you on this webinar can understand that. So addressing the needs of the population groups that face multiple levels of stigma, combined with the experiences of marginalization and discrimination, such as racism, transphobia, sexism, colonization, classism, ableism, and could go on. So those are the key principles very briefly, and I invite you, of course, to dive into that. It's a great resource with lots of care taken from many consultations and conversations, learning from experts who are already doing this work. So the guide, I think another important element is that it doesn't prescribe a single pathway to implementing or creating transformative change. It's just really about taking inspiration from what others have done and the resources that they've used, and then carefully determining how their approaches could be applied and adapted to your context. So next slide, please. So within the guide, a key feature is the theory of change model, which is divided into 3 distinct sections to help organizations address structural stigma. I'll talk a little bit briefly about each kind of high-level section. So first, we're talking about context. I think it's important to understand that any organization looking to address mental health or substance use related structural stigma first requires an understanding of what's needed. That means you need to identify and acknowledge structural inequities and power asymmetries that currently exist. You got to look at your current norms, policies, and behaviors and have a vision for change and think, how can we do things differently? In the middle zone here, the success factors. So these are the things that ensure the success of a change initiative. For example, social interactions, relationships, and behaviors, such as teamwork and information sharing. These factors are vital to breaking down and rebuilding health systems that better meet the needs of people living with mental health or substance use health problems or illnesses. And finally, sustainability. We always want, we talk about million pilot projects. We really want this to be something that is transformative and sustainable. So dismantling structural stigma will not happen overnight. I mentioned that earlier. It requires sustained long-term efforts to change culture, policies, practices, and relationship. And from our research, we found that the most successful and sustainable interventions to address structural stigma have co-designed processes into which new norms and approaches to care are gradually embedded. And then building trust and support among all stakeholders is especially important, especially for those who are resistant to the change in the first place. So that's just a very brief overview of some of the wonderful elements of the implementation guide. I will share a QR code with you further down in the deck after our panel presentation, but I really want to just jump forward and let the experts speak. So if you'll advance to the next slide, please, Sydney. We are going to have, you can just go right ahead on to the next one with the pictures. That'd be great. Very, very pleased to be joined by 3 wonderful individuals here today who are graciously sharing their expertise about this. First off, we have Samaria Nancy Cardinal. Samaria is an Indigenous therapy specialist and a passionate advocate against structural stigma within the mental health system. As a proud Blackfoot Métis and a member of the Opatimiswak Métis Nation of Alberta, Samaria brings a unique perspective shaped by her lived experience with stigma and harm in mental health care. With a master in social work and clinical practice, Samaria leads her private practice, Flower in the Wind Therapy, where she provides culturally sensitive therapy to Indigenous communities in Alberta. Her approach integrates traditional healing practices, offering a holistic path to mental wellness. In addition to her therapeutic work, Samaria is an author and a public speaker. She serves as an advisor for the Mental Health Commission of Canada and Healthcare Excellence Canada, and is an active member of Patients for Patient Safety Canada. Her commitment to improving mental health care for Indigenous people and her dedication to reducing stigma make her an influential voice in the field. Thanks for joining, Samaria. We also are joined by Janet Butler. Janet is a registered nurse with a registered nurse and clinical nurse educator with the Addiction Recovery and Community Healthcare team, and was one of the champion and change makers who helped drive the development of the implementation guide. So this is at the Royal Alexandra Hospital in Edmonton. With over 20 years of nursing experience in surgery and intensive care, Janet joined the ARCH, which is that program, that community health team I spoke of earlier, in 2021. In the interest of eliminating stigma, she advocates for stronger harm reduction, education for healthcare workers, and practical evidence-based strategies. Thanks for joining, Janet. And finally, Dr. Stephanie Knack is a senior research consultant with the Mental Health Commission and is a core member of the research team on the structural stigma work that we lead here. Stephanie's research specializes in mental illness and substance use related stigma. She's led multiple major projects for the Mental Health Commission of Canada on stigma and stigma reduction in Canada, and her research is published widely in peer-reviewed literature. So thanks again for everyone for joining us here today, and we're really excited to get started. So I will kick it off. I'll be facilitating a Q&A with our three wonderful panelists, and we ask that you save and put any questions into the chat. We'll have a few minutes at the end of the session to answer some of those.
Oh, I stopped share. Is that, it seemed, would you like
Yeah,
me
that's fine. No problem. We're just going to a conversation now, so that's great.
Yeah.
So I'll get started. So first and foremost, from your perspective, what comes to mind when you think about structural stigma, and how do you think structural stigma related to mental health and substance use health impacts individuals' willingness to seek help? I'll pass this one over to Janet to kick off some comments.
Thank you, Hannah. I think that structural stigma is getting a little bit harder to define because we're not so clearly seeing it in policies and procedures that used to exist now that we're very stigmatizing. Now we're seeing it, one very clear way to see it is in the allocation of resources and funding. And I think we spend a lot of time asking people that if they are struggling to please reach out for help. And you'll often hear that message that says, ask for help, help is available. But the truth is that because of the allocation of resources, help often isn't available. So now we're in this paradoxical area where we are asking people to reach out for help, but then when they do, help isn't available. And I think that just increases their feeling of invisibility, and certainly increases their sense of stigma, internalized stigma. They're on now long waiting lists, and then the social isolation is very unhelpful. So that's definitely somewhere I see it.
Absolutely, very true. I mean, resource allocation is an ongoing challenge for healthcare, but
Yeah.
particularly so in mental health and substance use health. Stephanie or Samaria, do you have any comments to add to Janet's?
Yeah, I can jump in for just, a quick, when I think about structural stigma, I think, first of all, I think it's important to distinguish it from interpersonal stigma. I think we go into a common default mode, at least I've seen this in a lot of the research I do, where we kind of default into conceptualizing stigma as a problem of individual attitudes and behaviors that we can just simply correct through education and awareness raising and training. And that's absolutely really important. It's necessary. We do need to have that education and that awareness raising and that training. But we're never going to fully eradicate stigma unless we actually focus on the structural, right? And until we really start noticing how stigma is actually embedded into our institutions and where it's embedded into our institutions. And then I think about distinguishing it from there in a couple of main ways that I think of structural stigma as the stuff that Carolina was talking about, through our actual structures, right? Our policies, our models of care, how we organize our healthcare services, as Janet mentioned, how we allocate our resources within healthcare, how we prioritize training or not training people in mental health and substance use. But the other way I see it too is how it manifests in cultures. So thinking about specific cultures of caring within our various healthcare spaces and settings and institutions. And I think when we shift our focus to stigma, thinking about stigma as a cultural problem instead of a problem of individuals, that also allows us to shift our focus of how we implement kind of training and awareness raising, because now we're not thinking about individual change, we're actually thinking about how can we change the way that whole setting kind of operates and functions at a cultural level. So those are some of the things I think about.
Very well stated. Yeah, thank you for your comments, Stephanie. Samaria, anything to add?
Yes, structural stigma in our mental health care system manifests in that mental health care is only for the rich. A lot of people out there right now, especially in our economy and what's happening in Canada, many people are experiencing mental health crises. They go and they try and get help. They don't get any. There's crisis counseling, one-on-one crisis counseling for maybe one appointment, and then that's it. And then they're told to go off and they'll be okay. Well, they're not. And so it's creating a lot of harm. And then what happens is these people have these mental health care issues, and the stress and everything affects the body. And then it goes into our regular healthcare system because they're manifesting in, heart problems and all sorts of things that are happening to their body because of the stress in their mind that is not being addressed. So this is a really endemic problem, and we really need to work on this.
Very, very beautifully put. And it's tragic how many people are not able to access care. So I'm really hoping that we start to see a shift, and there's great work happening in small pockets, but let's find a way to mobilize it nationally for sure. So I'll move on to the second question that's really focusing on why it's important to identify stigma embedded within the structures. We touched on that a little bit through the last one, but how, I'll go to you first, Stephanie. How would you recommend in getting started to disrupt and dismantle it?
Okay. So in terms of getting started, I guess there's a few things I would suggest. You'll see these are, very much principles that are described in the implementation guide. I'm a researcher, so I'm big on measurement. So I would say one way to start is start by counting, right? Start by capturing some kind of data, some kind of sense of how structural stigma is showing up. The saying goes, if it doesn't count until you count it. So selecting one or two indicators that make sense for your service area or your setting that can be used to get a baseline, some way to kind of get evidence and kind of capture what it is that you're trying to get a handle on. And then you can use those indicators and you can track progress over time. So maybe it's something around client experience, maybe it's something around number or type of complaints, maybe it's something about the compassion satisfaction of staff or moral distress of staff, burnout, that kind of thing. Another way to start is, as Hannah mentioned, involving people with lived and living experience in a meaningful way. That alone actually represents a disruption of structural stigma, and you are challenging structural stigma just by doing that. Because when you involve people with lived experience in a meaningful way, you're already starting to realign power relationships, and you're starting to rethink what we actually value as expertise and knowledge. So I think those would be two big ones. And then I would say, take a look at the implementation guide and look at that, and in particular, look at that first part of the model of change that Hannah described on context, because that's the part of the change model that really describes what it was in our case studies that were important factors or conditions for their success. These are the things that enabled them to kind of have that positive, sustainable change. And there were I think there's four things in that context piece, which is, identifying and ensuring a shared understanding of the problem. And, your measurement is going to help you do that. Articulating a clear vision for desired change, aligning values across diverse partners. So again, having that meaningful involvement of people with lived experience, make sure it allows you to help align those values and make sure that they stay aligned. And then also ensuring some kind of shared governance and payment structures. So again, you are kind of rectifying any kind of power imbalances in how you're setting up your partnerships and your relationships for structural change. I'll
Thanks, Stephanie.
leave it there. I think that's lots.
I mean, I could shout it from the rooftops. Involve people with lived experience. It's essential, definitely, for getting started. So thank you for reiterating that. And Janet, I'll go to you next, because you were heavily involved with the commission as we learned about the approaches that your ARCH program took. So do you have any advice or practical steps to share?
Yeah, mostly I'm just going to agree with Stephanie, both first on the implementation guide, which is really so helpful and just laid out so well, but mostly on including people with lived and living experience. So the ARCH team, or the Addiction Recovery Community Health team here at the Royal Alex in Edmonton, started a little over 10 years ago. And the first thing that they did was they worked with a research team and got involved people with lived and living experience. What happens when you're in the hospital? Is there anything that you found useful? Is there anything that you found particularly challenging, or what was a barrier for you? And they gathered that data, and that let them know how to move forward from there. And then once they had established the consult team here at the Royal Alex, then you have to really listen from everybody that's a part of that multidisciplinary team, because a pharmacist might have ideas or concerns that are very different than a nurse's ideas or concerns. And the nurse's ideas or concerns might be different than the client's ideas and concerns. And so giving everyone a sense of safety to feel like they can voice concerns, and that they're not going to be, judged, that everybody's here to listen, and that there's really kind of there's no wrong answers approach that we all hear about in school. And then I think being clear about your plan, what you plan to put in place. The ARCH team also put out a implementation manual for how they were going to be a consult service for clients within the inpatient setting, and what they're planned to do, and then reassess often what's working, what's not working. Continue to go back to those same people and ask them their concerns and ask them what's working for them, and just be as transparent as possible so that people will trust you, because without trust, you really have nothing, both from a client standpoint and from the members of the team.
Thanks for sharing, Janet. Yeah, I think the key about the going back to reassess is really critical as well. Ensuring things change, right? And needs evolve, and we're constantly getting, new clients and new patients and there's many different elements that can impact things. So just making sure that you're staying on top of the most current, atmosphere is definitely important. Samaria, I want to ask if you can speak to the importance of prioritizing meaningful participation of service users, community members, and other people with lived and living experience in the design and delivery of healthcare.
I believe it's extremely important. In the past, professionals, they were the experts, and they did not listen to anything, but they only had one perspective. And there is another perspective that is just as important. And that is the perspective of people with lived experience. I am lucky now because I am a person with that, and I'm also a provider. So I can see from both sides, which is really, really interesting. When people first started inviting me in and asking for my perspective, I was quite leery, because never before was asked. And if I did say something, my opinion was not considered valuable. But now things have really, really changed. And I walk with organizations at the current time that when you sit with them, everybody sits down together, everybody gives their opinion and gives their experiences, and everybody really listens. And that creates a level playing field where everybody is humble and everybody has open ears. And an elder once told me, we have 2 ears and 1 mouth, and we need to remember that. 2 ears to listen, 1 mouth to talk. So we need to start listening to each other, really listening, and understanding that every perspective is just as valid as ours, and even without an academic experience.
That's a wonderful advice. I cannot agree more. And I think that, you know, there's also a multitude of resources and frameworks out there on how to engage. The IAP2 framework is an excellent version if you're looking for guidance on where to start or something a little more structured on how to do that. But I mean, what Samaria has just shared is perfectly exactly that, you know, allow it. Like, I love that comment about walking with the organizations, because it's not, I mean, the last thing we want to do is bring people with lived experience to the table and then engage them in a tokenistic manner. So certainly ensuring that we're doing that in a meaningful way is critical. Stephanie, do you have any comments you want to add on? You were heavily involved in the Champion and Changemakers work and learned from a lot of these excellent examples. So anything to share?
Yeah, I could add on to that for sure. Yeah, in the context of our Champions and Changemakers project, which, just so everyone in the audience knows, that was the precursor project to the implementation guide. And it was a case study project. Janet and Arch was involved, and then 5 other initiatives as well that were all kind of exemplars of initiatives that were successfully challenging structural stigma in their particular work setting in their organizations. And all across the board, all of those different initiatives had that as one of their central mechanisms of change, if you will, one of their central components, that they really prioritize meaningful engagement of people with lived experience as true partners in that change process. But the other thing we learned is that they all kind of had different models and different ways of going about it. There wasn't just one right way or one best way that emerged. There were different structures. But they did have certain, right, that when it came to how they involve people with lived experience. And one was the relationship always existed in some kind of formal structure, right? It was embedded and formalized in some way. Another thing, and Hannah, you spoke to this, that all the initiatives were extremely cognizant of the harms of tokenism. So they were really committed to true engagement, and because of that, really quite intentional about rebalancing power relationships and addressing conflicts and tensions when they did arise. And I think all of the initiatives had examples of times where there was some tension, you know, kind of across partners. And then they were just really committed to kind of working through that in the moment, having those uncomfortable conversations so that they could, you know, move forward again, make sure that their values were aligned, and kind of move forward with the partnership in a really productive way. And then the third thing is that they all built remuneration models that reflected the value of the expertise and the expertise and the involvement being provided by people with lived experience, and then made sure that those remuneration models also worked for the people with lived experience, right? They were paid in a way and in a format and in an amount that that really valued their input. So I think those were some important common features to keep in mind.
Yeah, thanks for adding that last piece is about like the actual how you will be paying people too. You need to think that, you know, sometimes people don't have bank accounts, or, you know, so we're just being open to different methods to make sure that there is compensation, adequate compensation provided is essential. Janet, anything to add on to that before we move to the next question?
Maybe just a quick story. The Arch team here at the Royal Alex celebrated our 10-year anniversary recently, and we celebrated with a full-day education symposium, and we had speakers, mostly were physicians and researchers that spoke on different topics and did presentations, and it was great, and we had about 150 people attend. It was a really great day, but one of the sections that we had was we did an Ask the Experts panel, and our experts were 3 people with lived and living experience. And when we went back over the surveys at the end of our symposium to see, you know, what did people like, that was overwhelmingly the most, we got the best comments from people about that lived and living experience Ask the Experts panel, because people really do want to hear from people with lived experience and what are they going through. And they would talk about when they were in the hospital, and, you know, sometimes they actually were sort of giving us heck for different situations that they encountered, or they would mention things that they found helpful, and people really enjoyed that. So people do want to hear from people with lived experience as well. And certainly we can learn a lot from them. So.
Fantastic. Excellent advice. Thank you, Janet.
Yeah.
So it's just shifting gears a bit, but many of you on this call are likely working with vulnerable populations. Janet, I'm going to go back to you again. Can you comment on addressing the needs of these population groups that face multiple levels of stigma combined with the experiences of marginalization and discrimination?
Yeah, absolutely. Our patients are going through a lot of different things. Our consult service focuses on people that use drugs and alcohol and how that's affecting their life and how we can help with that. But of course, our patients are also facing housing insecurity in addition to their substance use. So it's very hard to start to plan ahead with somebody about how are we going to set them up for success in dealing with their substance use issues when they don't even have a home, and they're in such a dangerous and precarious situation. Everyone, of course, has opinions about the unhoused, and so that is an added level of stigma for them and trying to access care. We also work with moms on our maternity units, and that's another level of stigma there, because on the one hand, somebody who's about to be a parent is concerned about themselves and now also probably concerned about their you know, a child that's about to be born, but there's an extra level of shame and guilt. And so, you know, we need to be cognizant of the fact that they might be scared to ask for help, especially if they've had previous encounters with child and protective services that can have been really terrifying and horrible. And then in our emergency departments, some of our patients are in, you know, repeated visits. And even though electronic health records has been so helpful in many ways, it's now very easy for someone to look at somebody's chart and see that, oh, this person has been admitted to emerge multiple times in the last few months. And, you know, sometimes that can be really unhelpful, and that's not helping them. It makes for some people view people as less sympathetic, perhaps. So there's a lot going on, and we have to be aware of how all of these different issues commingle with each other, and it can really add to an existing situation.
Wonderfully put. I'll go to you next, Samaria, to provide some comments to that question. Oh, you're on mute, Samaria.
I think it's really, really important because if somebody is going to an emergency with multiple visits, there's a reason. And instead of just being told that, you know, seen for 5 minutes and asked to leave and don't get what their needs met, then this whole system is failing them, right? Our system is failing people that, you know, it's like when someone that has an addiction and they go into emergency, but they're going in because maybe they've broken their leg, and they lay there because the staff is thinking that they're drug seeking, right? And they don't get the care they need, while the patient next door to them maybe does have an alcohol problem, but they can't see it, but they're getting all the care that they need. And so we have this, you know, this bias and this what's going on in the system, and we need to level that playing field. We all carry biases in our hearts. That's what human beings do, you know. But it's important when we work in the healthcare system to really do some work on ourselves and find out what those biases are and really work on them so that we don't harm. We're all in this to help people. So to help the people, we all need to work together, and we need to heal ourselves in this process and all learn to walk together. Treat each other as human beings. That's what we are. I know I got into healthcare for that reason, as I wanted to help others. I don't want to harm others. And I'm sure everyone on this webinar has the same idea. So this change that needs to be created, let's walk together and do this. We can do it. It's beautiful.
Fantastic. Thank you so much, Samaria. We're running out of time. This is such a great conversation, but we have about 10 minutes left. I'm going to ask one more formal question, then we'll open it up to some of the questions that are coming in from the audience. So I think what's really an important takeaway is, if we're thinking about the role, often we put this job onto our health leaders, but we all do have a role to play. And if that's not the hat that you feel you can certainly bring this forward to someone who can kind of kickstart some of the change and action. But so thinking about the role of health leaders in tackling structural stigma. Samaria, I'll go back to you. You have shared a lot again, but any final kind of closing words and advice to folks on this call on what is that kind of key takeaway, that key role that you need to think about?
For me, we're all healthcare leaders. It doesn't matter what position that we carry in an organization. Think like a leader and do what's right. Remember, you're a human being. You're in healthcare for a reason. We can all create change. It doesn't matter what position we are on the team. We can do it. We can influence others in our team. We can influence others about us to create change. It doesn't just start with one person. It needs to spread, and let's spread this, right? Let's spread this beautiful idea, and let's all be a leader.
Amazing. Thank you. Janet, over to you.
Yeah, I couldn't agree more. I think agreeing that change is possible is very important, because sometimes it can feel like we're just all trying to trudge uphill, and are we ever actually going to make a difference? But we can make a big difference. And a big thing that I recommend too is that when you do see change happening right in front of you, when you do see those people stepping up, please take a moment, acknowledge them, congratulate them, thank them, because we're in this for the long haul, right? This is not something that we're going to have wrapped up next week. And so to prevent people from feeling like all they're hearing is negativity, really point out to them when they're doing a good job and thank them.
Excellent advice. Thank you, Janet. Stephanie, final comments.
Yeah, I absolutely love Samaria's and Janet's comments about, acknowledging the good when you see it, acknowledging those positive changes. And Samaria, I just, absolutely love your comment about, we are all leaders, right? We all have our own spheres of influence and control and advocacy that allows us to affect and support change. So I just couldn't agree more with that. I think the role really is for all of us one of leadership, right? Of taking leadership on the issue by kind of recognizing the importance of structural stigma, kind of prioritizing it, and doing what we can in our own sphere of influence and control, to make a positive difference. In terms of practical steps, I can suggest a few things. One is for sure around educating, right? Educating yourself, educating your staff on the topic. The Commission actually has a free online module for health leaders on structural stigma. So that's a great place to start. It only takes an hour or two to get through the whole thing. Reviewing the implementation guide and the Champions and Changemakers report is another great way to just kind of sensitize yourself to the topic more and really kind of, get more kind of ownership around the concept of structural stigma. Measurement, measurement is something I already talked about. And then the other thing I just want to mention as well about the role of leadership is becoming a champion of trauma-informed care and learning how to build trauma-informed systems of care is huge. And what we've been learning in our research is you can actually make some real gains in addressing structural stigma by taking a trauma-informed lens to policies, practices, models of care, assessments of physical space, etc. So the research I've been involved in has been around evaluating the stigma reduction impacts of training in trauma and resiliency informed care. And what we're finding in this research is that not only does it reduce stigma at the individual level amongst the participants who've taken the training, but once people have become trained and understand what trauma and resiliency informed care really looks and feels like, they start to see how absent it actually is in the structures of their workplace. So they start to see these barriers as examples of structural stigma And now they have a new lens and also a set of tools to actually know how they want to advocate or try to intervene to try and change some of those structures. So I think that's another kind of really important piece for leaders, for everyday leaders, as the Maria said.
Yeah, wonderful advice. Thank you so much for sharing that out. I mean, I hope the audience is feeling how grateful I am that we have each of you here to share all of the expertise that you have in this area. So thank you so much for providing your comments. I'm going to take the next few minutes to just go. We do have a few questions that came in from the audience. So please bear with me as I just go back to those. Earlier in the conversation, someone had asked about whether or not we would consider unwritten practices, which are often common as structural stigma. And maybe there's some comments around some of those things that aren't written in policies or standard practices that happen. Any advice to share about that? Perhaps Janet.
Sure. Thanks, Hannah. I work with hospital units, and all of our different units have their own sort of culture. And so that would be the sort of unwritten policies almost that you're talking about. We have a patient that's been on our team for a long time, and he's got a lot of things going on, and he can be a little bit hard to love sometimes. And so he tends to get moved from unit to unit because staff will sort of say that they need a break. They need a break from this guy. But then he landed on one unit, and he's been there now for an extended period of time. Nobody needs a break. They see the good in him. They treat him like their little brother, kind of. And so what is it about the culture of that particular unit as compared to others? I mean, everybody's got a lot going on, and you don't want to, judge, but I think that's where you find those sort of unwritten policies that this team, for whatever reason, has found a way to see the positive in this situation and work with him. And it's too bad sometimes it's hard to capture those things, but they certainly play a big role.
Fantastic, thank you. So Maria or Stephanie, any comments to add to that?
I think Janet really summed it up, but I would just kind of reiterate and say, yeah, absolutely. I think it counts. It is kind of, that speaks to that cultural piece of structural stigma.
Excellent. Thanks, Stephanie. I do want to take a minute to just ask a question about, we talk a lot about patient experience and we're looking at it from this side, but we know that, this has an impact on healthcare workers as well and frontline workers. Are there any comments that we could share? Maybe Stephanie, if you have anything, and Samaria, of course, but with the work that you've been leading through some of the research that you're doing, learning about the impact on the healthcare frontline workers and doing this work or experiencing, this through secondhand.
I do have, I can speak to one study that I've been involved in recently, and this was a study at an emergency department in Canada, where it was a qualitative investigation, just trying to understand how does stigma show up in this environment. And of course, we found all the types of things that we talked about today. But the other really powerful and concerning finding that came out of this research was just the incredible mental health toll structural stigma has on the staff. So our respondents talked at length about the moral distress they experience because they knew the conditions for mental health and substance use care were not good in the ED. They knew patients were often being harmed and actually becoming more ill while they were in the emergency department. They talked about how helpless and hopeless they felt for how to change things. They talked about emotionally shutting down to protect themselves because it was just so hard for them to keep saying, I'm so sorry, right, to another patient about the inadequacies of the system. So it really showed how much structural stigma affects all of us, right? They talked about how it contributed to burnout, compassion fatigue, low compassion satisfaction, and in some cases, they are even talking about leaving their jobs. So I think it really speaks to the fact that this is an issue for all of us.
Oh, you're muted, Hannah. You're muted, Hannah.
Perfect timing. I was just saying that excellent note to end it on there, Stephanie, but Samaria, I see you've unmuted as well. So if you'd like to provide any final comments as well, that'd be great.
Yes, the structural stigma is very hard on healthcare providers. When I became a provider, I just felt awful because I became a provider because I wanted to help my people and provide culturally appropriate therapy. But because of the intricacies of the system, I am not NIHB approved, which there are many Indigenous therapists that are not NIHB approved. And so therefore we can't help our people because our people can't afford to pay for therapy. So I've been working with some organizations, and a lot of us are trying to rectify that fact. And there are 2 organizations that I work with that have been able to provide free therapy by getting grants. One is also by a huge insurance company that is now paying for it. So now, we can, if we really work hard and we really want to do something, we can create change. And now I can help so many people because I'm involved with these organizations that see these gaps and are willing to work to change it. So, when I just graduated, I was very demeaned, and now I feel just very, very hopeful because I know these issues can be changed and we can do it. So don't lose heart.
Thank you so much, Samaria. Yeah, and we made it to time. That went incredibly fast. I think it was a wonderful conversation, and I really do thank all of you again for providing your input. We did mention earlier in the presentation that there are lots of resources already available through the Mental Health Commission and elsewhere, but we're happy to connect anybody with those. There are links within the slide deck, which will be circulated as well, but feel free, of course, to reach out to any of us. And I see Carolina has provided several links as well as our email in the chat also. So thanks again, and a big thank you to Sydney for inviting us here today to have this conversation with this network.
Well, thank you so much, Hannah and Carolina, and a special thank you to Stephanie, Samaria, and Janet for joining and sharing such wonderful and insightful discussion. It's just really wonderful to hear about these resources that are available, and accessing things like the guide that has just come out. And I really appreciate the wisdom of the panelists who have joined us today, and really, I think, provided us a lot to think about as we offer programs in CAPC and CPNP, and especially working with vulnerable families. And you've invited us into wonderful space to really reflect on where might we be having spaces that where stigma might be present, and where we can, work a little harder to bring that trauma-informed lens, and really putting ourselves in more of a safe and welcoming space. So thank you again to our friends at Mental Health Commission of Canada. I really appreciate your time and your wisdom and your energy. Thank you to everybody who joined us today. It was a really great turnout. And we'll be following up with links to recordings and slides and things like that. And if you do have a moment to fill out the survey link I popped in the chat a couple of times, please do. We'd love to hear your thoughts. And I think with that, we're bringing our time together to an end. Any final comments from Carolina or Hannah or any of the panelists? Okay.
Nope, I think that's great. Yeah, and I just echo everything that our panelists have said, and Samaria's advice for sure. Like we can do this. So yeah, I wish you all. I hope you leave out of this webinar inspired.
Thank you very much. Take care, everybody. Have a good rest of the day. Bye-bye.